Thanks everyone for attending our workshop today on advanced lung disease and lung transplant. We have a great program set up for you. We're going to start out talking about post-lung transplant, shared models of care and patient perspectives on that, then discuss the use of elexacaftor, tezacaftor, ivacaftor after lung transplant, and also the pharmacokinetics of that. Then we're going to transition and talk about advanced lung disease and predicting lung transplant and death, and then finally wrap up and talk about some exciting data from the CF Foundation Patient Registry. So we're going to talk about logistics right now. If you have questions to ask, you can submit them through the app, and we'll be following on the iPad, or you can get up and use the microphones. So with that, I will introduce our first speaker. This will be Grant Turner from the University of California in Los Angeles, UCLA. He is speaking about preferences of people with cystic fibrosis who have undergone a lung transplant. We're going to show our disclosures. And first, we'll say that show the NACFC presentation disclaimer. These do not represent the opinions of the CF Foundation. And then these are my disclosures, grant funding and a Vertex honorarium, and then grants disclosures as well. Thanks for remembering to do that. And then the other thing to know is that we'll have 15 minutes for each talk and about 5 to 7 minutes for questions.
Hello, everyone. My name is Grant Turner. I'm at UCLA, and today, on behalf of our overall team from UCLA Lung Transplant and the Long Beach Cystic Fibrosis Program, I'm going to talk about preferences of people with cystic fibrosis who have undergone a lung transplant. Same presentation disclaimer, same disclosures. So my objectives are going to be describing trends in lung transplant for people with cystic fibrosis that I think the majority of us know, but a quick refresher. Evaluating patient with CF's values regarding their care after a lung transplant, and then contrasting the proposed two models of post-lung transplant CF care. So as a little bit of background, CF was 15% of adult lung transplants in 2021, but this has been steadily decreasing, which is a very exciting new finding since the ETI has come on the market with 61 lung transplants last year. I know personally at our institution, we haven't done one in 2 years, which is excellent. And the problem, though, is that even though the number of lung transplants is going down, there are still a lot of people with lung transplants that are alive and need long-term care afterwards. And anecdotally, this care has been fragmented, that people with CF haven't known if they should go back to their or back to their CF center, if everything should be managed by their lung transplant team, or exactly how that should happen. The CF Foundation came up with consensus statements regarding the care of people with CF after lung transplants, and their number one recommendation is that the CF lung transplant recipient should follow up with their multidisciplinary CF care team within 6 to 12 months to resume extrapulmonary CF care, and that communication is essential. But is this actually happening, and what do the people with CF think about this? So as a result of ongoing work in the CF Lung Transplant Consortium, which is sponsored by the Cystic Fibrosis Foundation, they created the CF Lung Transplant Transition, Learning, and Leadership Collaborative, which is a mouthful, but the LTT-LLC, trying to combine lung transplant and CF programs together, not necessarily at the same site, in order to increase partnerships and figure out if we can improve transitions to and from transplant and work on other QI projects together. And so UCLA Lung Transplant and Long Beach Memorial Cystic Fibrosis decided to endeavor on this project. Even though we are 30 miles apart, depends on traffic how long it takes, we are quite far apart in terms of our collaboration prior to this. While we are colleagues, it wasn't as clear-cut beforehand. And so early on in the LTT LLC, the main projects were related to trying to create a dashboard in order to improve referrals and making sure that information made its way back to the CF Center afterwards, and making sure that patients were returning to their CF program. And then we went into the continuation phase, and we're trying to find other QI projects in order to learn more about our collaboration and how we can best take care of patients. And so the question then became, do people with CF place value in returning to their CF center? And if so, what components are they actually finding value with or essential to go to their CF center with versus being at their transplant center? In order to query this, we created a 25-question survey that was a mix of multiple choice and free text. And we looked at all lung transplant patients with CF that was followed at UCLA. And this is already a little bit problematic. I'm sure you're raising an eyebrow because this is going to involve lots of Southern California CF centers or potentially people that aren't followed at a CF center. So while we can't drill down specifically that people think Long Beach is excellent or that UCLA is excellent, we're able to get larger sort of thoughts from those lung transplant patients. This was determined to be IRB exempt. It was distributed via email and in clinic over a 6-month period. Going into the results, so 51% of our patients that are followed at UCLA completed the survey, and you can see that 50% of those people were followed at either not UCLA or not at Long Beach. About 39% of the patients were followed by the UCLA Cystic Fibrosis Center, and 11% followed by the Long Beach Cystic Fibrosis Center. 78% of the individuals were seen regularly in a CF clinic, and the median was every 6 months. And you can see the breakdown of how often people were seen on that bar chart. We then get into some free text, which I think is really illustrative of what the individual people are thinking. And the question first is, why aren't you regularly seen in a CF clinic if they said that they weren't? And a lot of the responses were related to how their symptoms of CF had seemed to disappear and that CF felt like it was on a back burner because of all of the transplant responsibilities. As we know, transplant is a full-time job in the first year. I always tell my patients that they're going to be seeing so much of me, they're going to be sick of me. And like our UCLA building, they're going to be sick of coming there. And it's a lot of appointments, a lot of labs. And so CF seems to be on a back burner. And then people think that their transplant center is taking care of them in terms of their cystic fibrosis, that they're handling their annual tests, and maybe they only need to go as needed to their CF center if they have specific issues. So then we asked, do you think returning to your CF clinic after your lung transplant is an efficient use of your time? Not just should you, but is it efficient? Over half said yes, and that their CF clinic has a unique lens, that they're constantly following research, like coming to NACFC, and knowing about specific issues related to GI, dietary, all of the CF medications, and how we can implement some of those new findings into their care plan, because it's not just lungs. 33% said maybe, that they're up to date on the new meds, but almost everything's taken care of at transplant, so why am I adding another clinic visit? And 11% said no, that they haven't had as much time for it and transplant handles everything, which I think is a reasonable thing most of us are hearing anecdotally as well. So then we wanted to break it down into specific parts of the care of a person with CF that may be handled by their CF clinic or their lung transplant clinic, and if they placed value on each of those respective places taking care of them. So sinus care, pulmonary care, CF-related diabetes and osteoporosis, digestive disease, pulmonary rehab, and vaccinations. And we broke it down excellent, good, average, and poor. I think this is the area that's going to be difficult to interpret because everyone is going to different CF centers. And so you can see the overall, people thought that it was excellent or good for almost everything in relation to all of the 6 different areas that we asked about. So not able to draw strong conclusions that there's one specific area. And we didn't specifically ask the endocrine and digestive questions of the lung transplant clinic because those aren't usually managed as closely. But you can see, thankfully, that people think 100% excellent of pulmonary care of their lung transplant clinic. Which is a good finding, obviously. But again, concerning that the CF clinic side, we weren't able to break it down quite as much since this was of multiple centers. We then wanted to know, are people seeing a nutritionist or a social worker outside of CF clinic? Because that can be a huge value add, having the multidisciplinary team model where lung transplant doesn't have that. And for the most part, people were not seeing social workers and nutritionists out of CF clinic, which I think can be a huge area that we can add care after transplant because those issues are not going away. And then we asked the ultimate satisfaction question. Thankfully, the majority of people were very satisfied or satisfied with both their CF clinic and lung transplant clinic. And we did have a commentary after this and gave specific feedback to centers about that. During our 3-month sort of catch-up with Long Beach and ourselves, we realized that we maybe should have added one more question of how often does the person with CF think they should be seen in the CF clinic? And unfortunately, it was spread out amongst the recipient or the people who hadn't answered yet between 3, 6, and 12 months or annually or never. So I think this, again, sort of shows the spread of what people think of in returning to their CF clinic. So the majority of CF and lung transplant patients are seen at their CF clinic. Their median visit is about every 6 months, and they do find value in the extrapulmonary care. It's just hard to break down exactly since this was a multiple CF clinic model. And really appreciate our findings on new research and medications, like everything we're learning here. CF Clinic is likely the only time that people with CF are seeing nutrition, social work, and that multidisciplinary team. We didn't ask about other things like pharmacy, physical therapy, other important components, and had variable thoughts on when they should be seen. And I think that variability also exists within our community, that there's this excellent paper that just came out about models of post-transplant care for individuals with CF, and there really is no consensus on what the best model of care is. So there was these 2 models that were proposed, one that there's separate CF and transplant teams with excellent communication between them, and then model 2 where everything is managed by one transplant team, hopefully with CF experience at one institution that then refers out, and having clear delineations of roles and responsibilities. If you wanted to see that in pictographic form, this was also from the paper. Model 1 is shared. Model 2, transplant coordinates everything, hopefully with a transplant physician that knows and understands cystic fibrosis. I think a really interesting part is then the CF Foundation during that in the supplemental material asked specifically questions to people with CF as well as physicians, but I wanted to pull out what do people with CF think their individual post-lung transplant and CF care would look like, and the answers are similarly mixed in terms of what they thought versus what our patients thought, that not all of them agreed that shared knowledge between CF and transplant teams is necessary, that the North American version was 60%, so 40% didn't feel like it was necessary, that sharing protocols was less than half again, that they regularly communicate about my care was less than half. But I think those are all really important things, and every person with CF will have very different views potentially about this. So I think the big take home is that while we are trying to ask what do all people with CF value in terms of their CF clinic and transplant care, every person with CF is an individual and is going to find different values in regards to that. And so while we are going to have broad recommendations, we should really be asking the individual what they value and making sure that their symptoms are managed appropriately. That CF and lung transplant centers really should collaborate in a shared model for the best outcomes for people with CF and making sure that everyone is well up to date, that us CF providers are educating us lung transplant providers about all of the new things you're learning at NACFC and beyond. They should continue collaboration for new treatments, malignancy screening recommendations, and there's upcoming clinician-facing documentation from the CF Foundation to clinicians with a great breakdown of who should be managing what and the timelines. I don't know if that was 15 minutes or not because the time kept refreshing, but I hope that that was close to 15 minutes, and I'm happy to take questions.
Great work. Thank you very much for your presentation, and we'll take questions from the audience, and we'll go first to Dr. Christopher Goss.
Chris Goss, University of Washington. I don't think this is working, but what's happening is the number of CF patients getting transplanted is falling quite dramatically. How do you think this is going to change when there are fewer and fewer post-transplant patients? And the expertise in CF transplant was quite deep, and a third of the patients were CF patients. What is the solution to that problem? And does this give you any guidance?
Do you want to repeat the question?
Yeah, so the question was, as the number of people with CF getting lung transplants steeply declines, lung transplant centers are going to not have as much knowledge about CF specifically because they're not going to be taking care of it as much. And so what do we do moving forward? I think that the CF Foundation setting up specific collaborations between CF and lung transplant programs is an excellent thought, and continuing that moving forward so that education can be bi-directional. Because I think as CF providers, we're also going to struggle, when should we be sending people for transplant? And there's a new paper coming out potentially about that. But I think having that bi-directional communication is going to continue to be so important. We know that people who are cared for, are transplanted at a lung transplant center that's connected with a CF center do better. And having those collaborations ongoing are going to be such a key component to making sure that people with CF are getting excellent care.
That's a great point. Good communication is always is ideal. How do you communicate with the patients about who they should reach out to for each of the different problems that can arise? What's your experience with that?
I think every individual CF is a little bit different, and even looking in the comments of this survey, that people are so close with their CF center, and so they may be going directly to them for a lot of things, or they may be very distant from their CF center. And so I think having that individualized model will be really important, but making sure they have one person that they know they should reach out to for their sinuses, or one person about their stomach, is so important. But that's, again, where that collaboration comes in. And that's not just doctor-to-doctor collaboration, but every patient is going to have a transplant nurse coordinator, and they're also going to have a CF nurse coordinator. So making sure that those connections are happening.
Yeah, I think not letting things fall through the cracks is the biggest piece for that, especially malignancy screening, colon cancer screening especially, is really critical so that they know who is telling them when they need to get their colonoscopy, among other things.
Definitely.
We have one more question here.
Hi, Sheila Sivan from Sydney, Australia. Just a quick question. What about, potential transplant-related complications like renal failure, renal cancers, need for renal transplants, that sort of thing? Do you get a feeling as to who's managing that? Is that the transplant teams generally, or the CF teams? That being said, also the colon cancer screening, like who's doing what?
So your question is, if a person with CF goes for a kidney transplant, who's managing
For
things?
example, complications from a transplant, say
Oh, yeah.
using TAC, or whatever the reason, they're getting renal failure and potentially need for a renal transplant.
Yeah.
Who would manage things like that?
I think that would definitely fall in the camp of the lung transplant team, because they're the experts in managing tacrolimus and referring people either for a safety net kidney within the first year, or long-term have those collaborations with kidney transplant. But the CF center may be the ones getting labs sometimes, or seeing some of those trends. And so making sure that they're communicating with the lung transplant team. Again, sort of making sure those clear communication lines are open.
Thank you.
Thank you.
We have time for one more question, and we have one through the app. So what do we do about a transplant center with poor communication to the CF care center?
That is a great question.
Just reading it as it's written.
Yeah. I think that there are always going to be people within centers that maybe communication is not their number one skill. And so potentially finding individuals within each center that are better at communicating would help alleviate that. So again, and it doesn't always have to be MD to MD communication. It can be RN to RN. It can be NP to NP. It doesn't have to be just MD to MD. And I think a lot of times it feels like it needs to be that way. But finding one person potentially that is passionate about it and can be a good go-between at each center is so important. And for example, our CFF LTT LLC included our social worker, our pre-transplant coordinator, our post-transplant coordinator, and then you can see the long list of people at Long Beach as well that were involved: research coordinators, nurses, social workers. So it was incredibly important to have connections at both places.
Excellent. Well, thank you very much.
Thanks.
I will set up Nora's slides if you want to introduce her.
It's not working. In my dual role, I will now introduce our next speaker. So next is Nora Burtis, who's a fellow at the University of Washington, and she's going to talk about the use of elexacaftor, tezacaftor, ivacaftor in lung transplant recipients with cystic fibrosis in the U.S., a CFF patient registry analysis.
Thank you for the opportunity to present today. I'll be talking about the use of ETI after transplant in the United States. I have no relationships to disclose related to this presentation. I have received grant funding through the NIH. So I think the first thing to talk about is why even consider using ETI in patients who have undergone a lung transplant. ETI was originally approved based on its ability to improve pulmonary function in people who have not been transplanted, so why even consider this? And the argument we will make is that lung transplant recipients still have CF, and they have CF that has extrapulmonary manifestations. I think some of the most important manifestations for patients who have undergone transplant is the sinus disease that they continue to have, as well as pancreatic disease, diabetes, malnutrition, low BMI. And we know that these extrapulmonary manifestations of CF impact the health of people who have undergone a lung transplant. There is data that people with more severe genotypes have worse post-transplant survival. Additionally, people who are low BMI before they undergo their lung transplant, if they do not recover to a normal BMI level within a year after transplant, they have worse one-year conditional survival. And finally, there's data supporting that sinus disease can actually contribute to recolonization and pulmonary allograft infections after transplant. We also know that ETI can impact these extrapulmonary manifestations after CF. The original clinical trials of ETI in people who had not undergone a lung transplant showed an average increase of 1 point in their BMI by week 24. Additionally, there's increasing observational data that at least for some patient, ETI improves sinus disease and glycemic control. So that leads me to next talk about what do we already know about the use of ETI amongst people who've undergone a lung transplant. Well, obviously these patients were excluded from the original ETI clinical trials. But based on a study that was conducted in 2020 of the CF lung transplant consortium sites, 13% of patients already in 2020 were being prescribed ETI after their lung transplant. That study showed us that there was a really large amount of variability amongst the proportion of patients at each transplant center that were being prescribed ETI after transplant. So the x-axis of this graph shows us all the different transplant programs in the study. It was anonymous, so that's why you see the letters A, B, C, D. The black bars are the number of lung transplant recipients at each center. And then the dotted line that you see on the screen is the proportion of lung transplant recipients at those centers who are prescribed ETI. And you can see it doesn't really seem to be related to the number of lung transplant recipients that they're caring for. And the prescription rate varied all the way from as low as 1% to as high as 35% of post-transplant patients at these centers being prescribed ETI. We also know some things about trends in ETI prescription amongst the non-transplant population. So this data from 2022 shows us that among the middle column is people who are prescribed modulator therapy, and the column on the right is people who are eligible for modulator therapy but are not prescribed that therapy. And we can see that those prescribed modulator therapy, private insurance makes up a higher proportion of that group. And those who are eligible for modulators but are not prescribed modulators, there's a slightly higher proportion of people on Medicaid. There are similar trends that we can see with race and ethnicity in the non-transplant population. Again, this is data for the United States. And we can see amongst people who are eligible but not prescribed modulators, that Black and Hispanic patients make up a larger proportion of patients in those groups. So this leads me to our research question. So we wanted to know what is the current prevalence of ETI use after lung transplant in the United States. And we also wanted to know what factors are associated with ETI use after lung transplant in the US. In terms of methods, we looked at lung transplant recipients who had ETI-eligible genotypes who were in the Cystic Fibrosis Foundation patient registry, and our study went through the end of December 2022. In terms of methods, we use multivariable logistic regression to identify factors that we hypothesized a priority to be associated with ETI prescription after transplant. In terms of our hypothesized factors, we thought sinus disease, diabetes, and low BMI would be associated with ETI prescription, and this was mainly based on a number of case reports where these diseases were listed as the indication for starting ETI after transplant. We also thought insurance status, race, ethnicity would be associated with ETI prescription based on the non-transplant population data. And we thought that CF center prescribing practice and F508del genotype would also potentially be associated with ETI prescription. In terms of defining CF center prescribing practice, we categorize CF centers both by the size, the number of patients they had who were post-transplant, as well as the proportion who were prescribed ETI after transplant. So those who had fewer than 10 transplant recipients, we classified them as small centers, and we actually did not further classify the proportion of patients they had on ETI because we felt their numbers were too small to reliably say what proportion of people were on ETI. And then amongst those that were larger centers, we said centers were low prescribing if they had 0 or 1 patient on ETI. They were medium prescribing if up to 49% of patients were on ETI, and they were high prescribing if over 50% of the patients at their center were prescribed ETI after transplant. In terms of our patient population, we looked at lung transplant recipients in the CFF patient registry who were alive as of October 2019, which is when ETI was approved by the FDA in the United States. We excluded patients if they did not have ETI eligible genotypes or if their genotype was unknown in the registry. We also excluded patients if they had no data in the registry since 2018, or if they had no data in the registry after they underwent their lung transplant. There's a variable for the first date being prescribed ETI in the registry. Those patients where the variable was missing, we said that they were unexposed to ETI, and those who had a defined variable date, we counted them as being exposed to ETI, though we only counted them as exposed to ETI after transplant if their ETI prescription date was after their date of first lung transplant. And we found overall 488 patients in the registry were exposed to ETI after transplant, and 1,178 patients were unexposed to ETI, meaning that 29% of patients in the registry as of the end of 2022 are being prescribed ETI following their lung transplant. In terms of characteristics of this population, the average age was 39 years old. About half of the patients were female. The breakdown of race and ethnicity was pretty equal between the ETI exposed and the ETI unexposed. And then we really saw a lot of differences related to the center prescribing practice. So only 14% of patients were at a high prescribing CF center in our sample. However, 30% of those exposed to ETI were receiving their care at a high prescribing center. Similarly, only 11% of patients were at a low prescribing CF center, while 15% unexposed to ETI were at a low center versus 1% of those exposed to ETI were at a low prescribing center. In terms of the results of our logistic regression, we found that compared to being at a high prescribing center, patients who were at a low prescribing CF center and a middle prescribing CF center were significantly less likely to be prescribed ETI after transplant. Additionally, those who had ETI eligible genotypes but no copies of F508del were also less likely to be prescribed ETI after their lung transplant. Interestingly, diabetes status, obesity, insurance, ethnicity, and race, none of those things were significantly associated with being prescribed ETI after transplant. And then kind of as we hypothesized, those patients who had a low BMI or who had sinus disease were more likely to be prescribed ETI after their lung transplant. So overall, over 25% of patients in the CFF patient registry were prescribed ETI after transplant as of the end of 2022. Low BMI and sinus disease were positively associated with being prescribed ETI after transplant, while patients who were at low or middle prescribing CF centers or who had no copies of F508del were less likely to receive ETI after transplant. I want to thank all the people in the research team, and then also thank the patients who contributed their data to the registry, as well as the staff who collected this data.
Excellent. Thank you so much, Nora, for that presentation. And we already have a question at the microphone.
Hi, Jordan Donuts, University of Minnesota. Do you have any data on how many folks started and then stopped after transplant for whatever reason, side effects, efficacy?
Yeah, that's an excellent question. The previous CF lung transplant consortium study that I cited found that about 40% of patients prescribed ETI after transplant stopped ETI after transplant. So there's some data about that. We are in the process of trying to figure out how frequently patients stopped ETI after transplant. It's a little bit challenging to assess with the registry data, but we do think it's probably a significant number.
Pierre-Régis Burgel from France. Nice meeting you. So, if I remember well, in your original paper in 2022, a determinant of prescription was the timing from lung transplantation, which means that many people who had been prescribed ETI, they had transplant for many years already. They were in their 5th year, 6 years post-transplant. Did you try to include this?
Yes, I didn't include this in my presentation, but it's on my poster. The average year of transplant was 2014, and that was the same both for people exposed to ETI and people unexposed.
Yeah, and I'll just add that the common practice is to stop it at the time of transplant at almost all transplant centers. And so that may skew the data a bit to people being further out because the clinical practice, and we'll talk about drug interactions momentarily, but the drug interactions make people hesitant to continue it in that early phase. Another question?
Alan Ramirez, University of Louisville. Related to that question, do you have data on how soon after transplant that Trikafta was started?
For many of the patients, it was many years, but the median year of transplant was 2014 in our study, so it would have been at least 5 years.
Go ahead, and then we'll go to the online questions.
Hi there, Chris Bennon, Boston Children's. Linking to the previous presentation when you talked about the shared care model, so the question is now, who is responsible to restart modulators after lung transplant? Because, as you said, Kathy, most centers stop it at transplant. I would do the same, I did the same. And so who's going to start it? Because if sinus disease is one of the driving factors, and if we look at this nice CF Foundation, modeling where sinus disease is grouped, well, for me, as a lung transplant physician, I would always say the nose is just a finger of the lung, so it belongs to me, but maybe, the CF physician would think differently.
Yeah, that's a great question. My understanding is I think it varies based on what center that you're at, and I think it varies a little bit to the number of transplant physicians in the program. If they are CF physicians, then I think they're sort of more willing to restart modulators, but my understanding is that practice varies quite a bit.
So the bottom line is, as you said, the communication out, isn't it?
Yes.
Really, because of the drug interactions too. It's so easy for a lung transplant doctor to start an azole and not realize that we have to adjust the Trikafta. I'm going to ask an online question, if that's okay. Was there any commentary or anecdotal commentaries of which of the CF genotypes that were seen to be more likely prescribed other than Delta 508? Did you look at other broad categories of genotypes?
We did not, so I do not know.
Okay, in person.
Thank you. Cecilia Tabarro from Toronto. I just have a curious question, and of course we haven't used them post-transplant, but what was the reason for a low BMI on these post-transplant patients when we have to deal many times with the opposite?
Sorry, can you ask that again?
What is the reason for the low BMI post-transplant on these patients? So I wonder if there is anything missing or maybe better nutritional, maybe care post-transplant or so, because low BMI post-transplant is really rare in our program, at least.
Yeah, I think, oh, let me touch that. Yeah, I think at least some patients still are low BMI post-transplant, like we saw in one of the studies that I cited related to BMI recovery. I honestly don't know why some people recover their BMI and others don't.
And go ahead. Yeah, the low BMI population is a small percentage of people who have persistently low BMI after lung transplant, but it's certainly present in the CFF registry. And I kind of wonder if they're more likely to show up in the CF registry because they're having nutritional issues and need to have nutrition support from the CF center. So we may get a skewed population in that way in the CF registry too. We are doing, well, it's 50, we have 3 minutes left.
Okay, another online question. Wondering if you looked at liver disease as a factor for prescribing ETI or not. Excellent.
That's a great question. We actually did not look at liver disease, but I think that would be an interesting thing to look at.
It could be negatively
Associated, yeah.
Did you look at all at the dosing, if people were given full dose, or the registry isn't specific about exact dosing, but has a couple drop downs there, I know?
Yeah, we did not. The variable that we used in the registry was the date that ETI was prescribed, and we did not examine any dosing information as part of the study, but it's, an important question in these patients who undergo transplant.
These are all excellent questions. Sorry, they're not necessarily answerable. Curious why FEV1 was not included as a factor to start ETI, given it was prescribed many years after transplant.
Why FEV1 was not a factor?
Yeah.
Oh, I think actually I forgot to list it as a factor, but we actually did include it in our analysis. We had a hypothesis potentially maybe patients might get started on ETI if they had really advanced CLAD in anticipation that they may be evaluated for a second transplant. So we did include FEV1 less than 30%. Sorry, I just didn't mention it, and found that that was not a significant association.
Great. Thank you so much.
Thank you.
So we're going to go on to our next talk by Jennifer Gimbalot from the University of Arkansas. She will be talking about elexacaftor, tezacaftor, ivacaftor concentrations that are similar between transplanted and non-transplanted people with CF.
Thank you for that introduction, and also thank you, Dr. Burtis, for the excellent groundwork to why we would study this. I'm Jennifer Gimbalot at the University of Arkansas for Medical Sciences and Arkansas Children's Hospital. Thanks to organizers and the moderators for inviting me here today. These are my disclosures. Okay. So as Dr. Burtis already said, the use of modulator therapy in lung transplant recipients has not been consistent, and there has been some debate about whether or not this should be done. And as has already been described, lung transplant is an end-stage lung treatment option for people with CF, and we do know that extrapulmonary manifestations do affect transplant outcomes. And we also know that elexacaftor, tezacaftor, ivacaftor, or ETI do benefit extrapulmonary manifestations. And so this really raised that question: should ETI be used in transplant recipients who are receiving immunosuppressive therapies? So there are a number of pros and cons to this approach. Of course, we have already discussed that improvement of sinus disease, weight gain, a variety of improvements in GI symptoms, and reduction in Pseudomonas aeruginosa with its relationship to CLAD are all very important considerations. But on the flip side of that, there have been a number of reports for poor tolerability with a high rate of discontinuation, increased reports of side effects, and specifically pertinent to my talk, drug interactions and toxicity concerns, with potential need for increased monitoring through therapeutic drug monitoring. The availability of dose titration for ETI is quite limited, with only a limited number of formulations, and therapeutic drug monitoring is not standardized for ETI if ETI concentrations were affected. So talking a little bit more about drug interactions, the graph or the figure that you see here is a complicated interaction of drug metabolism enzymes and transporters that reflect a number of components after ingestion of a given drug. ETI is a complex 3-drug regimen plus 4 major human metabolites in addition to other potentially less common metabolites that may circulate as well. And there's also potential interaction with other drugs in CF. And what you're looking at here is the potential for components of ETI to interact with tacrolimus, for example. But it actually is fairly simplistic. It does not take into account all of the drug metabolism enzymes and transporters that could be involved, nor does it account for the rate of absorption, differences in gut motility, GI, pH, and other things that can also affect absorption, which also subsequently affects metabolism and transport. And then that's the first step before it goes to first pass metabolism in the liver. And so it's a very complicated process that makes it very difficult to predict exactly what will happen in drug interactions. And so the best way to assess this is to actually look at the concentrations themselves. And so that's what we decided to do. And so we decided to evaluate ETI pharmacokinetics in transplant recipients, and we are going to focus on this first visit that we had in our study, which was an intensive sampling study from 0 to 12 hours, 12 hours chosen for feasibility purposes, and we collected 9 different samples over the course of that to really evaluate not only the concentrations at any given point in time, but to understand the absorption and distribution of the drugs. We then follow that up with quantitation through a mass spec analysis that was published in 2022 and is validated to FDA standards. Participants could not be on any other drugs, excuse me, with known interactions such as azole antifungals. And so this is the first slide I'm going to show you about our results. These are concentration time curves. They represent individuals' absorption, distribution, and elimination of compounds over time. As I mentioned, because of feasibility, we only collected up to 12 hours, and so we flipped the 0-hour concentration to 24 so that we could fully look at the curve. What you're looking at here are our group of non-transplant pharmacokinetic data in the solid lines. The shaded gray area is the estimated effective concentrations for each compound. And so I hope that you can appreciate that there's a significant variability in between different people and also over time in terms of when patients will reach different points. So where they get to the highest concentration, where they get to the lowest concentration, and how long it takes them to eliminate the drug. This is transplant pharmacokinetics and the dotted lines, and you can see that the patterns look very similar. And this is with them superimposed. So as you can see, they are virtually indistinguishable from each other. You would not be able to tell the difference if I did not denote them differently with the dotted line. And we also completed linear mix modeling to look at the differences between groups and also over time and see no significant differences for any of the compounds for these 2 groups. The next thing that we did was non-compartmental analysis, which is a descriptive analysis of concentration time data. And what I'm showing here for simplicity is the minimum concentration, the maximum concentration, and the average concentration. But we also looked at all of the other standard non-compartmental analysis variables, such as time to maximal concentration, the half-life, the volume of distribution, clearance, and the area under the curve, which is another measure of drug exposure. And what you're seeing here are the non-transplant versus the transplant groups for each of the variables that I'm showing you today compared to each other. And as you can see, there was no significant differences between those 2 groups for any parameter, and that was true for all of the other ones that we looked at as well. We also don't see any trends towards differences, meaning that we just don't really see any close to significant p-values. We don't see any grouping of samples in one way or another that is really significant. The other thing that's important is that the variability between the 2 groups is also quite similar. So to conclude from this, we really saw no evidence of significant differences for elexacaftor, tezacaftor, or ivacaftor in the non-transplant versus the transplant groups, even looking over this time period, the entire day of the concentration time curve. And this is important because during the earlier studies, one of the items that some people were saying was the reason they were concerned about it was, would ETI even be effective? Would its concentrations also be influenced to make it less effective or less responsive? And we don't see evidence that that is occurring. But we do still have this concern about potential for side effects. As was mentioned earlier today, lung transplant recipients do report up to a 42% discontinuation rate. The most frequently cited reason was for side effects. And although in the general population of people with CF who take ETI, there is about a potential associated side effects up to 82%, but only 6% are considered serious adverse events and rare discontinuation in general CF population, and that is from a recent 2023 meta-analysis. So this led to the question that even though you don't see a lot of differences in the parent compounds, what about differences in metabolites or metabolite production? Could that be a potential etiology for increase in side effects? We do have potential drug interactions that could cause differences in metabolites, and so we wanted to look at that as well. And so we did a similar analysis looking at all of the major metabolites. So elexacaftor M23, tezacaftor M1, ivacaftor M1, and ivacaftor M6 are all the major metabolites for these three compounds. We similarly are showing here the minimum and maximum concentrations and the average concentrations, which are a non-compartmental analysis parameter. And similarly, we looked at all of the other PK parameters that I mentioned earlier. And we do not see a significant difference between the non-transplant group and the transplant group for any of these major human metabolites. So this data further shows that there is no evidence of significant differences for ETI metabolites in the non-transplant versus the transplant groups. Now we'd like to place the data into clinical context with the estimated effective concentrations. So what you're looking at here is a concentration or exposure response curve. Along the x-axis are the plot of the concentrations, and along the y-axis is the biological response. And a relationship between these two variables is fitted to try to identify what the effective concentrations are. And this is usually part, or essentially always part, of drug development and dose finding. And so for modulator therapy and ETI specifically, the EC50 and the EC90 were considered the target therapeutic concentrations. And those can be derived from other public sources. Below the EC50 would be a suboptimal response, and above the EC90 would be the target, basically trying to get the maximum number of people to get the maximal effect of the drug. So these values can be derived and estimated from a published work from Dr. Tsai in 2020, and I have indicated those here in the gray shaded areas. And what we did is to estimate the proportions, looking to see, even though the absolute mean concentrations may not be different, do we have a different distribution of the proportions within that therapeutic range or outside of it? And we see no significant differences in the proportions within that therapeutic range, below or above. This is a busy slide with our table for our demographics. It can be perused at more detail at our poster, but the main differences that we see between our two groups are that our transplant recipients were a little bit older, there were more males included in that group, but otherwise they were very, very similar in terms of the duration of time that they were on DTI, transplant with fewer days on ETI, and then nearly identical pre-modulator and post-modulator sweat chlorides showing responsiveness to ETI. To summarize, ETI concentrations are similar in transplant and non-transplant patients. There is no evidence of difference between transplant patients taking tacrolimus and non-transplant patients. And it's really important to understand the pharmacokinetics of these compounds and their metabolites so that we can use that information to help us plan clinical decision making. We also didn't go into in detail, but tacrolimus levels were manageable, as has been shown already in multiple studies, and evaluating tacrolimus over time was not a point of this study because that's already been shown to be manageable, and tacrolimus levels are elevated at ETI, but are able to be managed with standard of care monitoring. There's unlikely to be a clinically significant impact on ETI concentrations when tacrolimus is co-administered, and so therefore that can be more reassuring to clinicians that this is not an issue when considering ETI for a patient. So in conclusion, the use of ETI in lung transplant patients can be considered. Tacrolimus toxicity can be managed using standard of care monitoring. ETI compounds remain within the effective range that we know of, and no evidence of excessive concentrations for either the parent compounds or metabolites compared to the non-transplant group that could explain the increased side effects that we see in this population. I'd like to acknowledge the participants and research teams who make this work possible. Lots of people come together in multiple different places to contribute to the study design and the conduct and analysis of the study. And I know I miss people, but it just takes a village to do this, and I think each and every one of you.
What a wonderful talk. Thank you for presenting the data and sharing the findings. It's a question that's really relevant to both the CF and transplant communities, as we talked about earlier with sharing care and drug interactions. When you think about people who may be on additional medications like an antifungal azole, how do you recommend adjusting the drug doses?
Well, definitely the label for ETI has very specific instructions for different types of drugs that are known to interact and how they're known to interact with ETI. And so that would be my recommendation, to follow the label. Adding an azole antifungal, as an example, does increase additional complexities because there are the interactions with the drug enzymes, metabolism enzymes and transporters are very complex. And so there may be additional potential for additional research in that area. But for now, I think with no evidence and difference between the two on tacrolimus and ETI, that there's no reason to think that the label should not have adequate information for that.
Okay, great. Are there any other questions?
There's an online one. Do you think non-transplant patients are more likely to continue ETI despite side effects because of the positive impact on lung function, or transplant patients are using it for other reasons?
So I can certainly speculate, but that is definitely possible. I mean, of course, we know that ETI has had a profound improvement or resulted in profound improvements in lung function. But those people who really can experience a profound improvement in extrapulmonary manifestations will probably be more likely to continue. And I think it would be an area of for further research. But also, there are an additional burden of care within lung transplant recipients, even above and beyond the high burden of care that people with CF who don't have a transplant have as well. And so that also probably plays into whether they choose to continue or not.
Did the patients were they receiving standard dose of ETI?
Oh, that was from the other one. What about psychiatric side effects?
Oh, psychiatric side effects.
Well, I can answer the first question first. To be in this study, it was required to be on standard dosing. So everyone, both in the non-transplant and transplant groups, were on standard dosing without any dose modification.
And then the other one is, what about psychiatric side effects of ETI after transplant?
Okay, so there's currently no systematic evidence that concentrations directly relate to side effects, neuropsychiatric side effects. It is certainly possible, and there is some anecdotal and case series data that supports that hypothesis, but further study is needed for that. We were not specifically assessing for that in this study, so I can't comment on this population.
A question I've had is, while we know that tacrolimus is manageable on ETI, do you think that the goal trough for a patient may impact their tolerability? Did we look at the tacro trough goals for these patients? Because some centers will do 12 to 14, some years out, the average was 10 years out, some maybe 5 to 7 at that point. So does the amount of tacrolimus in their system affect the ETI?
It is possible that there's a dose effect, but that's something that we'll have to study in the next time because it's a really good question.
But we did have the tacro level.
But yes, we did have the tacro level at the time of the visit, and it was within the range that for the participants.
Yeah, and it was somewhere in the
6.5.
6.5.
Yes, I meant to highlight that on my slide. It was on the table.
Oh, okay. So I wonder if maybe higher, if people are in that early phase, they may have more.
It's possible.
Yeah.
Yes, we'd have to study that though. Yeah.
Next study.
There's one more online question. When will we have the possibility of having levels of ETI in lung transplants? Will that be possible?
Currently at National Jewish Health, there is a reference laboratory for sending samples out. I will say that there's a symposium this afternoon, Symposium 5, where we're going to talk about this more extensively. And at present, ETI therapeutic drug monitoring, which is what I think the question is referring to, is not standardized, and single samples are very difficult to interpret because we don't have enough information about it. But that time is coming, and evidence is emerging every day. All right.
Thank you so much.
Thank you.
You introduce?
Yes. Okay. Okay, next we have, let me get back to the right area, Allison Love, who's going to speak on the impact of ETI on the predicted 3-year risk of death or lung transplant for individuals with advanced CF lung disease from the University of British Columbia.
Hi, everyone. I'm Allison. I am a respirologist at UBC and a cystic fibrosis clinician practicing at St. Paul's Hospital in Vancouver, Canada. Thank you so much for coming to our talk today. I'm really thrilled to share our research and also excited to share it's been accepted for publication this year in the Annals of American Thoracic Society. So look forward to that. I'll be sharing our work looking at risk of death or lung transplant for individuals with I'll be sharing the results of our work looking at risk of death or lung transplant for individuals with advanced CF lung disease treated with elexacaftor, tezacaftor, ivacaftor. I have no conflicts of interest to disclose for this presentation. Elexacaftor, tezacaftor, ivacaftor, as we know, is associated with profound improvements in health outcomes for people with cystic fibrosis. Individuals with FEV1 less than 40% predicted were not included in these pivotal phase 3 trials for ETI. However, subsequent studies have shown comparable clinical improvements for individuals with advanced CF lung disease. In particular, ETI has been found to be associated with reduction in rates of death or lung transplant within this cohort. In this study published in the Journal of Cystic Fibrosis in 2022, 331 individuals with advanced CF lung disease were prescribed ETI via the Early Access Program in the French CF Registry. Of the 331 individuals, 65 were considered lung transplant candidates prior to starting ETI. After approximately 1 year of treatment with ETI, only 2 actually underwent lung transplant and 2 were listed for lung transplant. The investigators also found a reduction in treatment burden, IV antibiotic use, long-term oxygen therapy, and use of non-invasive ventilation. It's important to note that the majority of the data that has been published so far regarding the reduction in death or lung transplant with ETI has been descriptive, and there's not yet been a study looking at reduction in the number of expected outcomes within this group. Many prognostic scores have been developed in cystic fibrosis in an effort to try and predict the risk of negative outcomes like death or lung transplant in individuals with advanced CF lung disease. This prognostic score, which was published in the Journal of Cystic Fibrosis in 2017, was originally developed and cross-validated using the French CF Registry with over 2,000 patients. It was later independently validated in both the Canadian CF Registry and the CF Foundation Patient Registry. This score includes 8 clinical variables that have been found to correlate with risk of death or lung transplant within the subsequent 3 years. Importantly, this score was designed and validated prior to the use of ETI. The 8 variables that are included in the score are FEV1, expressed as a percent predicted, body mass index, Burkholderia cepacia positivity in the sputum, the number of IV antibiotics in the preceding year, and as well hospitalization, oral corticosteroid use, long-term oxygen therapy, and non-invasive ventilation use in the preceding year. Each of the continuous variables is converted to a categorical variable in order to generate a numeric value that is used in the summative score, and each individual will have a summative overall score ranging from a minimum score of 0 up to a maximum possible score of 9.5. Based on the summative score for each particular individual, they can either then be classified into the low risk category, which corresponds with a 1% estimated risk of death or lung transplant over the subsequent 3 years, moderate risk category, which corresponds with a 10% risk, or high risk category, which corresponds with a 55% estimated risk of death or lung transplant over the subsequent 3 years. Back to our study then, we aim to compare the predicted incidence of death or lung transplant prior to starting ETI to the true observed outcomes after starting treatment for individuals with advanced CF lung disease. In our study, we included individuals from the Canadian CF Registry of at least 18 years of age from January 1st, 2019 to December 31st, 2020. These individuals would have had an FEV1 less than or equal to 40% predicted and were started on ETI by December 31st, 2020 through the Special Access Program. In Canada, ETI was not publicly funded until 2021. And prior to 2021, ETI was available through the Special Access Program. This is for individuals with advanced CF lung disease who had at least 1 copy of the F508del CFTR genetic mutation, and applications were granted on a case-by-case basis. We excluded any individuals who were missing any of the 8 variables needed to calculate the baseline prognostic score, and we isolated a separate cohort of untreated controls. These were individuals with advanced CF lung disease who were ineligible for ETI based on their genotype at the time of the Special Access Program. Data from the Canadian CF Registry was captured until December 31st, 2023, in order to observe the actual number of death or lung transplant events that occurred over that 3-year period. The outcomes of our study, our primary outcome was to compare the predicted 3-year risk of death or lung transplant to the actual observed number of events in individuals who were treated with ETI. Our secondary outcomes were first to compare the death or lung transplant rate in the treatment cohort to the untreated control group. And we also analyzed change in lung function and BMI after starting ETI within the treatment cohort. With regards to our statistical analysis, again, we first calculated the baseline prognostic score for each of the individuals within each of the cohorts by the previously described methods. Again, each individual was then classified based on their individual score into either low, moderate, or high risk. And then we performed a relative risk ratio calculation for the primary outcome, whereby we multiplied the number of individuals within each risk category by the percent risk for that category. Predicted events were compared to actual observed events using McNamar's chi-squared test, and comparisons between continuous variables were performed using paired t-tests. We identified 345 individuals from the Canadian CF Registry who were at least 18 years of age and had an FEV1 less than or equal to 40% predicted. Of that group, 187 were excluded, as although they were eligible for ETI based on their genotype, they were not prescribed ETI through the Special Access Program by December 31st, 2020. An additional 15 individuals were excluded as they were missing their baseline variables for the risk score. And we isolated that untreated control group, which contained 41 individuals. This left us with 102 individuals for our primary analysis, of which 86 had follow-up lung function and BMI data for our secondary outcome. Looking at the demographics between our two cohorts, starting with the treatment cohort who started ETI via the Special Access Program, about 51% were male, 95% identified as Caucasian, with a median age of about 33.7. As mentioned, all the individuals in the treatment cohort had at least one copy of the F508del CFTR genetic mutation, and about 30% were previously on other CFTR modulators prior to starting ETI. In comparison with the untreated control group, we found significant differences in ethnicity, genotype, exocrine pancreatic status, and there were also less individuals in the untreated control group that were previously on other CFTR modulators. Looking at the clinical variables that are included in the prognostic score, again, in the treatment cohort who started on ETI, we found an average FEV1 of about 28% predicted and a median BMI of 19.8. The majority of individuals in the treatment cohort had been prescribed at least one course of IV antibiotic therapy and been hospitalized in the preceding year. In comparison with the untreated control group, we found slightly higher lung function, and there were less individuals on long-term oxygen therapy in the year prior to the analysis. First, just looking at change in lung function and BMI within the treatment cohort, we saw statistically significant improvements in both lung FEV1 and BMI within about 1 year of starting ETI, again in the treatment cohort. Moving on to our primary outcome, again, you can see the distribution of the number of individuals within each of the risk categories based on their individual summative risk scores. Using our relative risk ratio calculation, we would have expected approximately 35 death or lung transplant events over the subsequent 3-year period, or an incidence of about 34%. Using real data from the Canadian Cystic Fibrosis Registry over that 3-year period, less than 5 actual death or lung transplant events were observed using the registry data corresponding with a relative risk of 0.08. We were unable to disclose the exact number of events that occurred, as the Canadian Cystic Fibrosis Registry requires that number to be suppressed when it's less than 5 to protect patient anonymity. Moving on to our secondary outcome, this is with the untreated control group. So these are individuals with FEV1 less than 40% predicted, but were not eligible or were not prescribed ETI through the Special Access Program as they were not eligible based on their genotype, the untreated control group. Again, you can see the distribution of individuals within each of the risk categories. Using our relative risk ratio calculation, we would have expected about 9 death or lung transplant events of the 41 individuals, or an incidence of 21%. And using real data from the Canadian Cystic Fibrosis Registry, we observed 20 actual death or lung transplant events, or an incidence of close to 50%. In comparison of the treatment group and the untreated control group, in the treatment group, we saw a significantly lower number of actual death or lung transplant events observed in the registry data than were predicted using the risk score. And in the untreated control group, we saw significantly more death or lung transplant events occur than were predicted using the risk score over that 3-year period. In comparison of the actual events in the treatment group compared to the actual events that were observed in the untreated control group, we calculated a relative risk of 0.06. There are multiple limitations to consider when interpreting the results of our study. Firstly, the risk score that we used was validated in the Canadian Cystic Fibrosis Registry using data from 2011 to 2014. Although ivacaftor was available in 2012, this was prior to the use of other earlier generation CFTR modulators. This, along with other advances in care since that time, may affect prognosis and make our predictions less applicable in current CF practice. The risk score that we used was not specifically validated in individuals with advanced CF lung disease. This may introduce bias as our cohort selected for potentially even higher risk individuals, as was seen in our untreated control group, which had worse outcomes than were predicted with the risk score. ETI was prescribed in the study during the period of the COVID-19 pandemic. The COVID-19 pandemic was thought to be potentially protective for individuals with CF by reducing exacerbations owing to enhanced public health measures. Regardless, we saw significant differences between our treatment and our untreated control group despite this. As mentioned, ETI was prescribed in the study through the Special Access Program. This may also introduce bias as this program was for people with the most advanced disease and on a case-by-case basis. Additionally, individuals with advanced CF lung disease may not have consented to enrollment in the Canadian CF Registry, and so their data was not available, may not have been available for our analysis. In conclusion, ETI reduces relative 3-year risk of death or lung transplant for individuals with advanced CF lung disease by greater than 90%. Updated prognostic models are required in the current era of CF, owing to significant advances in CF care that are affecting prognosis and improving outcomes. Modern prognostic models must account for those who are eligible and those who are not yet eligible for CFTR modulator or other future disease-modifying therapies. I would like to sincerely thank my supervisors, Dr. Badley Kwan and Dr. Alex Franciosi, as well as our co-authors, as well all the patients and families with CF who consent to having their data in the registry, and all the CF team members who work tirelessly to enter that data. Thank you for your attention.
I'll start with an online question. Is there a prognostic difference for untreated ETI-eligible patients versus untreated non-ETI-eligible patients? Could genotype alone impact prognosis? Yeah. Is there a prognostic difference for untreated ETI-eligible patients versus untreated non-ETI-eligible patients? Genotype alone impact prognosis?
46 that got excluded because they weren't yet prescribed ETI.
I think, yeah. We didn't look at that specifically. We did look at least like kind of baseline like clinical variables in the like ETA eligible but not prescribed versus the prescribed through the Special Access Program, and we found that there was a higher lung function in people who weren't on the Special Access Program compared to not, and higher BMI, which could correlate with prognosis. I think certainly genotype can influence prognosis. It didn't come out of the prognostic scores that I was reading about in terms of a significant variable, but we know that certain genotypes are associated with more severe disease, and so that would play a role.
Did all the ETI unexposed survive through December 2020, or did you include deaths that occurred between January 2019 and December 2020?
Did they have to be alive as of December 31st, 2020?
Yes, yeah. So the individuals had to be alive by December 31st, 2020 to be followed forward for the subsequent 3 years.
I have a question. So it looked like in the ETI prescribed group that they were more likely to be on long-term oxygen therapy. Do you think what we see in the US is that CF centers are less likely to refer people for transplant, even though they meet transplant referral criteria because they're on Trikafta? And so it's interesting that more of those people are on long-term oxygen. And so do you think that it could be influenced by the fact that so those people on ETI could be transplanted, but they're not being sent because they're on ETI, so they're stable. Do you see that in Canada as much? Do you think that could be an influence on the outcome numbers, since lung transplant is one of your outcomes?
That's an interesting question. We didn't look at, say, at the 3-year mark. We just looked at rates of death or lung transplant. We didn't look at how many of those individuals that were still alive were still on oxygen at that point, like after starting ETI. But certainly, yeah, acknowledging that can be another marker of advanced CF lung disease and raise flags about referral for lung transplant. To be honest, in the short duration of my training career, we haven't sent someone that's on ETI for lung transplant. And from what I can recall, maybe only a couple people actually on oxygen therapy at this point, but not meeting other referral criteria. So I think it's just a very complex landscape that we're dealing with now in terms of what are some other, is there other like comorbidities, for instance, or that should come into play in terms of prognosis and affecting when to refer for transplant.
Great.
Very hot topic.
Pierre-Régis Burgel from France. So you used our model, the prognostic model that we developed, and you found that it's completely outdated, and I completely agree. But then in your conclusion, you say we need to update these models, but do we really need new models? We have no more deaths, almost no more deaths, very few lung transplantations. How can you build a model on this, and do we need models?
You raise a really good point, because we know even without a study, we can all probably anecdotally from clinical experience identify that outcomes are improving, and less people are being transplanted, less people are dying. I think how models like this can be helpful in the current landscape of CF care is trying to identify patients who still might deteriorate over time with regards to their pulmonary status or extrapulmonary status. And there are still individuals on ETI that are moving towards transplant. And so, again, considering not only their kind of CF clinical variables, but comorbidities outside of their CF, how that might come into a role in terms of when to refer for transplant. I think there still may be a role for prognosticating in those individuals.
Yeah, absolutely. I agree with what you're saying there, and would say that there are still people who are dying with CF lung disease from CF lung disease, and we may be missing opportunities to identify those people. How to identify those people and make it so they don't miss their window, their opportunity is critical. And whether we can do it with large data models is a question mark. But I think a description of who is still dying from lung disease with CF on ETI, I think is a really important question.
Great.
Thank you so much.
Thank you. Thanks.
I'll do if you want to introduce, and I'll set up the slide.
Yes. And then last but certainly not least is Jonathan Todd from the Cystic Fibrosis Foundation. And he's going to talk about advanced CF lung disease in the CF patient registry, incidence of advanced CF lung disease and characteristics of that population. Welcome, Dr. Todd.
That was a great segue, too, to this talk.
Absolutely. I'm unreasonably tall, so I have to get this right.
And our time is not working, so you can look at my watch.
Okay,
here.
that sounds good. I want to thank the organizers for organizing the session and for inviting me to discuss a little bit of our work in the Foundation's patient registry. I have no relationships to disclose related to this presentation. So here we have, for this talk, we have kind of three kind of disparate goals. Want to understand the structure of the ACFLD data in the patient registry. Want to examine the incidence of ACFLD over time, and also want to demonstrate other uses of ACFLD data, sort of pique interest in the community for the use of this kind of novel data that we've been collecting since 2019. The ACFLD data forms have been collected since 2019. They are updated annually. Patients are excluded at lung transplant, and if already contributing ACFLD data, they stop contributing that data at transplant. But patients do continue to contribute ACFLD data even if their lung function improves above a qualifying threshold, which is obviously in the area of ETI something that happens frequently. We have 6 specific domains of data. In the ACFLD data, we have an annual table, blood gas, embolization, ICU admissions, an initiation table, and a 6-minute walk data as well. The ACFLD data forms are available via Port CF, and the questionnaires are actually available as an appendix in the CFFPR annual data report. How do we define ACFLD? We can do it through FEV1, less than 40% when stable, or being referred for lung transplantation evaluation, or one of several different characteristics, including a list here, several of which were not available in the main CFF patient registry prior to the addition of these new data forms. So we can use existing registry data to identify persons with CF with ACFLD. We can do that based upon FEV1. We can do that based upon complications. So available registry data on transplantation evaluation, oxygen therapy, pneumothorax, or massive hemoptysis. But there are problems with that calculation. That's likely an underestimate of prevalence or incidence because we have several domains of missing criteria. And also, the transplant waitlist data is not specific to lung transplantation. So in this analysis, we just did a simple incidence calculation. We excluded all patients with an ACFLD qualifying condition, whether it was FEV1 or the available ACFLD conditions in the main registry from 2010 to 2014. We then calculated incidence each year from 2015 to 2023, removing those new incident patients from subsequent years' calculations. Here's just a flow diagram of how we did the calculation. We started with 37,904 persons with CF with annual and encounter data between 2010 and 2023. We excluded about 6,500 patients for having prevalent ACFLD between 2010 and 2014, and those who did not have patient registry data after 2015, which left us 31,452 individuals to review for ACFLD. You'll note for each of these calculations that we reduce the denominator as incident patients are removed in subsequent years, and for loss to follow-up, for transplant, and for death. And you can see here that we sort of have a kind of a monotonic kind of lowering of incidence over time, starting with, in 2015, 3.9% incident ACFLD, going down to about 3% in 2019, and then you see a drop in 2020, and that sort of maintains down through 2023. This is just a graphic showing some of the new criteria and the new data forms. We have here hypercarbia, ICU respiratory, pulmonary hypertension, and 6-minute walk. So these are kind of new kind of qualifying conditions in the new data forms. And previous ICU admission for respiratory failure and 6-minute walk, less than 400 meters, were the most common new kind of qualifying conditions in the new data forms. Here we just have kind of a characteristics of persons with CF with incident ACFLD, and kind of going from 2019 to 2023. You see that over time the percentage of individuals with incident ACFLD is going down, and see the kind of disparate characteristics here. Now I just wanted to briefly touch upon a couple different really sort of queries that you can use these data here. Looking at 6-minute walk status by modulator status, looking at demographics, transplant referrals by several different demographics, and also by looking at kind of a cascade of care for transplants in this data. So one kind of query that we could use with this data is, how does 6-minute walk distance vary over time, stratified by use of a modulator? Here just is a violin plot of the 6-minute walk distance by year and modulator status. And you can see that there's sort of a trend for patients on modulators to have a increased 6-minute walk distance in comparison to those that are not on modulators. Then we looked at sort of an ACFLD cascade of care. So the question we're looking at is sort of beginning with an incident case, describe the ACFLD kind of care cascade to lung transplant. And this is something that is, when you have a lot of steps in a process, such as, starting with ACFLD going to having transplant discussions and evaluations and referrals to transplant programs and actual lung transplants. So we start with 100%. This graph is looking at the kind of 683 patients who had incident ACFLD in 2019, and you can see there's sort of a big jump in the data forms for the annual data being completed. So, and obviously there's very low numbers of actual lung transplants in this group. One thing, we wanted to kind of look at the difference between those who actually had their ACFLD annual data completed in the data forms and those that did not. The main difference we saw, the main difference between those that actually had that available annual data was older age. The patients were that had the kind of available ACFLD annual data. The median age was 30. For those that did not have that available was 23.7. We wanted to, recognizing that 2019 was the first year we had actually started collecting this data, we wanted to sort of repeat that kind of calculation, that care cascade in 2020. And actually we saw, a similar care cascade, actually a slightly smaller percentage that had annual data completed. So clearly that is an area to work on with regards to kind of the completeness of this data. And finally, we look at kind of the percentage of transplant referrals by year and race. And you can see here that over time, white patients tended to have a lower percentage of transplant referrals, and black patients tend to have an increase over time in the percentage of transplant referrals. Looking at it by ethnicity, we actually see Hispanic patients have a higher percentage of transplant referrals in comparison to non-Hispanic patients. And really, these are sort of queries, kind of just some examples to kind of whet your appetite to look at this data. But really, this data is now available for requests, and please contact us with new proposals. Thank you.
Thank you for that great talk and for reminding us that these data exist and are ready to be analyzed. We'll start with a question over here.
Yeah, that's a great question. I think the way we constructed the cascade, you essentially, they would be in that small percentage kind of that did not move on to the next step in the cascade, if I understood the question correctly. And yeah, I think that that's certainly the case, particularly with the success of ETI.
I have a quick question, and then Dr. Farrow will ask a question as well. Oh, no, he's not. I was wondering whether or not you have a breakdown of how people qualified for advanced CF lung disease, where almost all based on FEV1 less than 40%, or how often was it an ICU admission or massive hemoptysis or something else?
We did look at that, and I sort of focused on incidents here. The vast majority were for via FEV1, and I don't have the numbers off the top of my head, but the complication or proportion was relatively small in comparison to the FEV1, but certainly some patients had multiple
Right.
qualifying conditions.
Absolutely. Al?
Albert Farrow, CF Foundation. Thank you, Jonathan, for a great talk and whetting people's appetites. I just wanted to add to your answer to the previous question, which was, we had been planning to build this, and the world sort of changed on us. So we did have to, in real time, decide what we were going to do with those patients who had such a wonderful response and no longer really met the definition, but had previously met that definition. And we thought they'd be an interesting sub-cohort to continue to follow, since we had already started following them, to see what would happen to them over time. So we would like to continue to collect data on those patients over time. So thank you.
Yeah, and interestingly, the group that falls in that 40 to 50% range for the adults, we should still be talking about transplant once a year, and it would be nice to be able to capture that in the advanced CF lung disease form to see, are we actually talking about it or not? So.
Another in-person question.
Alan Ramirez, University of Louisville. Do you think that cascade of care looks differently depending on how transplant and CF in a particular center are related? For example, for those of us where the CF physician is also a transplant physician, does that cascade of care look different if the transplant physician is not a CF physician or if they're in separate institutions?
Yes. The short answer, I think, is yes. And I think it relates to the communication that that has been woven throughout all the talks. It's just the communication between the various roles at the CF care centers and the transplant teams, and that's all I can speculate on. But I would agree. I think that's true.
I had a quick question. So it seems like the proportion of people that are getting a complete ALD form is low, at least in the 2020 data. By complete, does that mean that they had all of the information there, or just that it was started and some of it's done? And then what do you think, two-part question, what do you think we should do to get that to 100%? Why are we not filling out ALD forms on everyone?
Yeah, that's a great question. I think it is not a full, complete, every single variable answered. They have some of the annual data included. So as far as methods to kind of increase that, I know with the next generation registry, there's a lot of thought being put into the structure of how that data is collected and ways to structure the forms to sort of maybe automate like inclusion in the annual data itself. So I think that is one route to sort of increase the actual proportion that are actually filling out these forms. But, I suspect issues of burden and these are new forms and education about kind of the availability of this data is still needed, I think.
Can I ask a quick follow-up before we go to Erin?
I was also going to just jump in on a response too.
Yeah.
But
Okay. Do you know if it's more complete or similarly complete in 21, 22, 23? Because I think you showed 2019 and 2020 were in the 17 to 20 something % complete rate, but is it better now?
We haven't looked at that yet. We had hoped that the 2019 was more of an anomaly because it was the first year doing it.
But 2020 was a weird
Yeah,
year.
that's true.
And we
Yeah.
didn't have a lot of in-person data collection. And so maybe it's better
Yep.
post-pandemic, optimistic. Go ahead.
Hi, Erin Tallarico from the CF Foundation. I just wanted to add to Jonathan's response. Thanks for the great talk and looking at this data. So big plug here to make sure if your programs are not entering data into the advanced lung disease case report forms, you do. There is additional funding tied to that for complete data sets. And then as Jonathan alluded to, we are working with our next generation registry colleagues to move away from a specific form focused on advanced lung disease in the next gen registry, and the advanced lung disease variables will be built into the main registry. So hopefully that will really help with our data collection.
Wonderful. Are there other questions?
I was just going to say, what is a complete data set? What are you describing? Erin isn't listening, but what are you describing as a complete data set for, especially for funding? I think people are always wondering, how do I get a complete data set for funding and maximize what I can do for my center?
I actually don't know the full details. Maybe Erin, you might be able to speak to that.
Yeah, so it's in the data entry guidelines what constitutes a full data set for funding, but Al had a great point. Even if someone didn't have a blood gas that year for whatever reason, still fill out everything that is applicable and submit it, because that's going to be important information as well. Whatever you have, put in there and submit for us.
And in the current version, you can't check anything to say the test was not done. It's just missing. But in the next gen, there's going to be a test not done button, so it will be easier to discern. This has been really great. Thank you so much for your talk. Thank you all for your wonderful talks. If you have any questions and you want to come up, please do. And we thank you for your time.